People have to understand we do a blood workup. We like to check pancreas level always. It's very, very rare to cause issues, especially with the lower doses. But we like to be safe.
You measure pancreatic enzymes in the stool?
We do it actually so far in the blood. We're going to be adding it, and we want them to have good sleep. We want to see their smartwatch data and help them. Some patients, they are premenopause, and we start talking about other part, which is the hormone replacement therapy. And our biggest part we have, which is like what we added with you guys in the last year, is doing the genetic testing. And that seriously became like one of our biggest package to help patient client long-term is doing the full genetics evaluation for them.
Welcome to the Precision Medicine Made Simple podcast, where we simplify the complex world of precision medicine. We're here to explore how personalized healthcare can empower you to understand and improve your health to live a longer and healthier life. Join us as we break down the latest in medical science into actionable insights. Let's make precision medicine accessible and actionable for everyone. This episode is sponsored by Biography Health, where DNA-powered healthcare is designed just for you. Biography Health is a HIPAA-compliant precision medicine platform that equips providers with AI-driven recommendations powered by your genetics, health history, and clinical insights, all while keeping data private, secure, and independent from large EHR systems. If you're a provider ready to bring precision medicine into your practice, visit biographyhealth.com to learn more. Or if you're a patient who wants your doctor to explore this, point them our way. We'll help them bring personalized healthcare to life. As a reminder, this episode is for educational purposes only. This episode is in no way a replacement for professional health advice. Please consult with your professional primary care provider for medical advice. If at any point you feel that a topic discussed on our podcast was misrepresented, or if you have additional insights that could enhance our discussions, we wholeheartedly encourage you to reach out to us. Your feedback is invaluable in helping us improve and in ensuring our content remains both informative and reflective of the latest developments in precision medicine.
Hey everybody, welcome to the Precision Medicine Made Simple podcast. I'm here joined with my co-host, Dr. Stanford. And then today we're joined by a physician who spent over 2 decades helping patients breathe easier and live healthier, quite literally. He's board certified in pulmonary medicine, critical care, sleep medicine, and clinical informatics. But what really stands out is how he connects modern medicine with real-world wellness. In 2024, he teamed up with his co-founder to launch the Longevity Clinic, actually the place that we are at right now, a place built around one simple idea that prevention and early detection shouldn't be an afterthought, but a foundation of lifelong health. So today, we're going to be exploring how that philosophy is changing the way that people are approaching aging, health span, and personalized care. Please give a warm welcome to Dr. Mohammad Jarbou.
Thank you.
Just to start off, in your background and in your history, how did the Longevity Clinic come to be to where it is now? So did you and Marmar meet? Marmar's his co-founder, by the way, while you were in residency? How did you do connect? And then
very good. Yeah, it's actually started as a hobby. So we're in medicine for the last 20 years, the practice fellowship in pulmonary, critical care medicine, sleep medicine. It had been always helping patients after they get diagnosed and after they get sick. And then after I established with patients, I found out that I talk to them more and more about prevention, about how they stay healthy, how they stay away from doctors. I joke with them, stay away from doctor as much as you can, but you have to work hard for it. In 2023, we were reading a book that I gave Marmar also. It's called Outlive. And I said, oh my God, I wish I wrote this book because it's a lot of ideas, a lot of thought. Dr. Peter Attia did really good with it. It is a great book, and it had a lot of science-based medicine. And then with the hobby, with us talking about the 3 pillars, wellness with fitness, plus nutrition, plus sleep medicine, that we can offer patient consultation services and do more for them to stay away from being sick. So we started that idea. We started as a hobby. We started doing some VO2 max testing for patients because we did not find anyone in the area, in the Midwest, doing it on a regular basis with physician support. So we started with the VO2 max testing, and it started getting more and more. We had more patient attention that they want us to help them with wellness, fitness, sleep, and then other areas. Prevention. That's the most important. Early diagnosis of disease, early diagnosis of cancer, and then we got into genetics also.
So VO2 max, personal question here.
Yes.
Wearables on VO2max.
Yeah.
Are they as accurate?
So very good question, because this is where also like a lot of our patients or clients, they ask the question. I encourage them to use their smartwatch to calculate the VO2max. The problem with what we have right now, it's only calculation dependent on your heart rate. But the gold standard is an actual measurement with a mask and see how much your maximum oxygen consumption when you are hitting like a zone 5 in cardiac workup. So I like the wearable. Absolutely, I like to use it every day. The only problem that it's not accurate absolute number, but it can give you the trend. It can give you that you're doing the right trend. So I can test you today, your VO2 max around 50, but your watch reading it as 40. I'll tell you, no problem. So the goal gonna be for you to work with that watch and try to reach 45 to 47, which correlate with 50 to 57 in the future with the actual measurement. We cannot do the measurement on daily basis. We can do this daily, and it can give you the guidance. The more data you get, the more you're gonna do the right work out for you. So it is a good way to measure and see the trend in general, but the absolute number is always by the true VO2 max testing in the lab.
And if things change like your weight, you know, since it's a per kilogram, when I was looking at mine, I go, gosh, I would have thought I was better than that. And I looked and I adjusted, my weight wasn't input properly. So when I put in my accurate rate, got what seemed like a more realistic number. Let's just say that.
And we get a lot, our clients, they surprised when we do the actual test for them. And it's be different than the calculation from their smartwatch. But again, we do everything possible weight related. We do our best like to test them using a treadmill or a bike. And we'll be glad to do it, by the way, for you while you're here. I think, absolutely. I think we can record some of it with the, and
You can do it.
we keep this information private.
Oh,
So we're not gonna,
Can you explain a little bit about, how the gold standard max VO2 works, how you measure how much oxygen is extracted, et cetera?
So very good. So again, we want you to have some effort, and we want to see how much maximum oxygen consumption when you are going in cardiac zone. So depending on your age, depending on your race, we try to get you to calculate what's the zone 5 for you. And then we see what's your preferred measure. Is it?
And zone 5 is?
So zone 5, so what we do, we calculate what's the maximum heart rate for you. Okay? So let's talk about you if you don't mind.
Yeah.
Okay? How old are you?
I'm 30.
30. So the simple way we'll say your maximum heart rate is 190. Okay? That is the zone 5. And then what we say that every zone you start at around 50%. So for you is around 95. That is where we start with the zone 1. And we go from around 95, let's say, to 18 more points. So I'm going to say 20. So I'm going to say 95 to 115 is your zone 1. 115 to 135 is zone 2. 135 to 155, zone 3. Zone 4 is 155 to 75, and 175 to 195 is zone 5. Okay? Now, and this is, again, rough estimate. We like always to calculate it more accurately, exactly. So your zone 5 going to be 175 to 195. What we try to do, we can get you the cardiac workout, treadmill or bike, or wherever your preferred method. Some people prefer rowing machine. Some prefer to do it outdoor. Firefighter, we do it in the ladder while they're wearing their stuff, and we can use that machine, okay? So we have a tight mask, it's disconnected, it's a great machine to have. And what we do, we watch your resting heart rate, and then we start pushing it and see where your cardiac zone. And then we calculate how much oxygen you're taking from air, from the 21%, and we calculate how much is coming out. And then we calculate also carbon dioxide, we calculate minute ventilation, which is how many times you breathe per minute with the tidal volume.
So is it measuring your exact minute ventilation?
Yes. And what we do, actually, when we do it, we show it to you on the monitor. So the bike here, you see all your numbers. So you know where we are, and we want to push you to get to the level 5. Yes. So we try to get you. Now, I like to, like someone like you, I'll get you the test, okay? Someone old like me, I like my physician to review it before I do the test. So I want to be sure that I don't have atrial fibrillation. I don't have any, I want to know if you're taking beta blocker, if you're taking medication that can cut down the heart rate. So it's for me, I calculate depend on patient before we do the VO2 max testing. So someone young like you, healthy, we push you to the limit, okay? And that will give us the actual measurement for the VO2 max and the carbon dioxide and all that. Now, will be great, and we'll talk to you later about it, if we offered some time where we check lactic acid.
Oh, wow.
Yeah, so when you check the lactic acid, if we can get you below the threshold of the lactic acid.
How do you check it?
Because the blood,
Like a finger stick?
finger stick.
Yeah.
And it's even available, like we do it, it's a medical device, but it's even available on Amazon that you can buy it and you can do it in your own.
That's somewhat.
And we like to know what's your cardiac zone 2. Now, cardiac zone 2 is a little bit more complicated here, okay? So the cardiac 2, it's the area where you can work out cardio and you stay below the lactic acid threshold. And that is where you're pushing your powerhouse, your mitochondria inside the cell to have more work, and you can build up a better quality as your base for going up to the top, which is the VO2 max. So most of the best athletes on earth, they work 80 to 90% in zone 2, and they work the zone 5 only 10 to 15% a week. And that's how you build it. It's a pyramid. It's like you have to build the base first. So when we see patients, and this is where I used to do it with my clients in my office after I get them, like if they have an acute medical problem, and tell them, okay, this is what I need you to do. The first few weeks, you're out of shape. We started telling them smartwatch, just give me a walk. Walk 5 to 7,000, walk 7 to 10, depending on what's their base. And then I calculate for them what their zone 2, again, rough estimate. So I tell them, I want you to work more in your zone 2 and more like 2 to 3 times a week, 20 minutes. Bring your heart rate to 130, 140 and stay there. So you're pushing yourself, you're stressing yourself, but not you're building a lactic acid that much. And then once a week, give me a hit. Give me like one of these hard workout that you bring your heart rate almost to the max.
Wow. So I have 2 thoughts.
Yes, go ahead.
So first thought is, you mentioned that like for older patients, you look at like any pre-existing conditions.
Yes, absolutely, yeah.
But would you say that VO2 max could also be a signal for potentially what else might be wrong then?
Yeah. So if the patient cannot do it, we stop. We tell them, let's not measure the VO2 max. Okay, let's figure out what's going on. If they cannot achieve cardiac zone 5, if their number is extremely low, say, okay, hold on, let's do some workup and figure out what's underlying that we don't know about. Or if you have issues with sleep apnea that you're not sleeping, or if you have issues with asthma, or you have issues with underlying heart disease.
Yeah.
So now let's go back to the VO2 max. It's the best number to give us longevity. It's the best number to tell us. So if you walk in to see me and say, Dr. Jarbou, how can I tell how's my longevity going to be? I tell you, okay, longevity is not only how long you're going to live, but it's also the quality of life you're going to have.
The health span.
The health span and the lifespan. So the lifespan is how long, and the health span is how you're going to live this life. Is it going to be good quality or not? You tell me, did there one test? I'll tell you VO2 max. So the VO2 max, if we have patients that they are below average or low, and we work with them to improve it to above average, to excellent, to the elite, and there's no reason why every one of us to be in the elite for our age. It just needs hard work. I will give you better quality of life. I will give you longer life. The all-cause mortality will go down, and that like by 3 to 5 years. That's a huge. But
so you're buying half a decade.
yes, but you know, the thing which I've been doing for a few years with the VO2 max is the only number you cannot cheat. You cannot just go do workout for 1 week, come back and tell me, I need to test my VO2. No, you're going to see your VO2 max in your watch, in your smartwatch. It's so slowly, sometimes frustrating to improve.
Yeah.
But 3 months, 6 months, good workout, hitting zone 2, most of the time hitting zone 5. And we give our patient a specific program, something called Norwegian 4x4, which is 4-minute max, 4-minute rest. This is well studied.
Yeah. So that was what I was going to ask is, so you're talking about, zone 2 and then once a week, zone 5. Do you ever, how are you on the high intensity interval trainings? In other words, would you ever like tell them to mix in? So what do those protocols look like?
And on top of that, I would have assumed, because I feel like HIIT training has been, everyone says that you just need to increase your heart rate.
Yeah.
What's the point of
Exactly. And that's where,
doing HIIT training?
that's the reason why we really customize it, depend on what's your base, what's your ability right now to do it. I have patients, they're 80s, and I'm able to give them exact program. And I have patients, they're 25. And it's completely different. But this is the main issues. Like, okay, give me 3 times. So give me 3 times a week, 20 to 30 minutes with zone 2.
Yeah.
And then give me one session a week with the HIIT, with the maximum, to reach the maximum heart rate if it's safe. Now, I'm a big believer in personal trainer, honestly. I try to get my patient to do a lot of things on their own. Some they can, it's just to make it a habit. I think.
I know I can't. What a trainer is able to get out of me compared to what I can get out of
I agree with you
myself.
100%.
It's like night and day.
I think, yeah.
I feel like I worked out my entire life, but until I worked with
Personal trainer,
really
yes.
good trainers, my trainers don't like to be called trainers.
Yes, yeah, we're fine. I mean, they're
health and wellness consultants.
agreed. Yeah. I think we need to change it. I agree. Actually, I like that term.
Yeah.
And that's the reason why I partner with one, because I'm a big believer that it's the best investment you can do for your wellness. Again, your generation is a little bit different. Sorry, ma'am. Our generation, injuries is the biggest problem for us. For you, you have room, you can do stuff on your own, you can learn it.
Well, so what I am scared about this generation is and this is very niche and very specific because I have a younger brother and a lot of his generation is into vaping. Not saying my younger brother.
Yes,
like
vaping.
just like a lot of smoking.
So we're going to talk about it today. We need to talk about
What can we talk about? I mean,
yeah, because it's more than the pulmonary side, and that's really, vaping is becoming an issue. And it is one, so longevity, if we can teach it, it's all about habits, all about small micro habits that you can build and benefit from long term. The wellness, the going to the gym or working out with the personal trainer or wellness consultant is all about making it a habit. And then you take it over, and even if you travel, you keep doing it. Even if you're out of town, if your trainer is not available, preventing injuries. Now, a lot of new generation, I'm dealing with the vaping as the third problem. It's not as bad as smoking, for sure, cigarette, but it is bad. And nicotine, a lot of these young kids, they want, I mean, when I say young kids, I mean in their 20s,
right.
With all respect. So their 20s, they like the nicotine. They like the nicotine to help them with their anxiety, their stress. And then whenever we get a young client and we show them their risk, they show them their roadmap for wellness and to be in good shape, they make more easier for them to quit vaping than quitting cigarettes and smoking. So always we need to pick our fight to start with. I mean, I'm a big believer again in wellness. I'm a big believer in what we need to do for our clients to help them to get them in the right track. But you cannot do multiple changes at the same time.
Right. So like that, what was the book, Atomic Habits?
Yeah.
Yeah.
What's his name again?
James Clear.
Yeah.
Atomic Habits. It's an excellent book.
You need to, yeah.
Excellent book.
Those incremental changes and just sticking with it.
So, I mean, we've been talking about VO2 max then. I'm assuming there's still stuff missing that you don't get. Like, so we're talking about just the biomarker itself, right? And that could be signals for something else. But then before this podcast, you were talking about how you were still looking for something else.
Absolutely. So the main issue is that, I like to make it as a, like where to start and how we go take it to the next level. So the VO2 max, one of the best indicator for longevity. Okay. The muscle mass.
Probably the best.
The best, absolutely. I mean, I think then second is the muscle mass, which is like my generation did not, I believe, more in cardio than weightlifting. And I was wrong. Weightlifting is critical. Muscle mass is critical. And maintaining muscle mass is also huge for your longevity and the quality of your health span. But I tell my patient, I saw a patient last week, she's 88. I told her, I need to build up muscles. It's extremely hard, but I want you to come back in 6 months and flex. I want to see some muscle here. And she was laughing, and she understand me that, oh, seriously, there is no age you stop doing weightlifting. It's great for you, great for muscles, brain function, for your all like functional life. I want you to continue living a good quality of life and weightlifting with cardio. But again, we try to do it step by step. Get me the 3 times a week, add one weightlifting with a trainer because I don't want you to injure yourself. And then we do the next step, which we do a body composition scan, DEXA scan. That's standard for all my patients.
Perfect.
It's scale.
And do you do that here?
We have a contact with our local radiology.
And what's the method?
So they do the actual DEXA scan with the radiation, the full one. I believe like the VO2 max measurement, this is the gold standard to measure your body composition and to see what's your muscle mass, what's your bone density, and it will help me a lot because for us as male, we don't believe that we're going to have osteoporosis or osteopenia.
Oh, yeah.
And we're wrong. And we catch a lot of things and then we calculate the muscle mass and then it gives us exactly. And we don't have to do it every month. You can use a scale, smart scale, to give you an idea where you are, and it give you the trend. Because I want to see the muscle mass going up. I want to see the fat ratio going down. I want to be sure the bone density stay good. So like the VO2 max, we try to do it once every 6 months or once a year, and we see the progress. So that kind of second...
And you did the max VO2 here as well?
Yes, yeah. We do it downstairs, and again, we'll be glad to do the test, and you're gonna have an experience with it. I think
Can both of us just do it? I mean, you can compare VO2 max.
yeah, I'm in.
Sure.
I'm on the spot, Doctor.
Yeah, we are.
Oh, no, absolutely.
We are in the senior tab or like that.
So if you go on like OpenAI and go, how can I approximate? Yeah.
Oh, yes.
So I did that.
Very good question.
To check. That's why I realized there was this huge disparity between. So what is it, like a 6-minute walk and you check your heart rate?
Yes, 6 minutes, or you can do the exercise. A lot of
Or how fast
Garmin
walk a mile or what? I can't remember it.
Yeah, Garmin have a little bit different calculation than Apple in calculating the VO2 max. But both of them actually it's reasonably okay for long-term trend, but the absolute number is not correct, unfortunately. Yeah.
And so for non sequitur, but just I didn't get to ask this question before. So some people can for me, my 220 minus my age, I don't know, it's like 155, something like that. But I can get to like 165.
Yeah, that's fine.
So does that? So if you're at
the 220 is not very accurate, to be honest with you. We have much more accurate measurement that we set down, we put it on, and we get the patient exactly. And then the most important for us, it's the trend. These are safe ranges to give us some rough. Now, the zone 2, which is not correct zone 2, the one it's a little bit more confusing. We try to say 180 minus your age as a rough estimate to do workout. So whenever you do your cardio, I would like to be your heart rate 125 to 135. The other way I would tell you, do the cardio zone 2 while you short breath, but you can talk in full sentences.
Yeah.
I can have some conversation with you. You don't want to do it, but you can. If you start getting more short breath, more like hyperventilating, no, we're not in zone 2. We're building lactic acid. And then we go for the weightlifting and the muscle mass and all that with the DEXA scan. Again, we measure it once, and then we ask you to use a smart scale, and see the trend. And then we go to the nutrition part where we want you to do the cardio, we want you to do the muscle mass, and then we talk about your nutrition and how much protein you need to have, which type of diet, how we can give you the right diet. And again, it's not big changes. We like to do small changes, depend on your regular diet right now, and then adding more protein, and that's the protein, another big issue for us. People get are you serious? You want me to take 150 gram protein a day? Yes.
And that's not easy to do. You have to really have a protein dense diet. And I think this is one of the areas we wanted to get into. You mind if I
go for it.
So let's face it. I live in LA, and people are very generally far more in tune to what they eat, and they're just they're just a little advanced, in what we're talking about here. I can't help but notice that in mid-Missouri, it looks like there's just not the awareness of what needs to happen. I don't think there's even an awareness that they can alter the course of the trajectory.
I think it's changing, though. I think it is changing. I think the newer generation, they understand it more. They getting it. It's harder for me to convince like a 60, 70 years old patient how much their diet had to be changing, how much they need to adapt with the term. I don't. Do you know what sarcopenia means?
Sarcopenia?
Yeah. Do you know what osteopenia or osteoporosis?
That's bone density.
Very good. Yes. So it's decreasing the bone density. Sarcopenia is the decrease in muscle mass with aging. And it is a big chronic problem that we have that, again, I'm showing it to patients in their body composition scan, DEXA scan. I'm showing them how much their muscle mass and how much it needs to be. And then the protein intake is a big part of it. And then their diet. And then with diet, it's like, I know everyone talk about high protein diet. We have protein in everything from chips to powder to... There's multiple ways to get supplement, but it's all your food. You're like, how can you get clean protein, high protein diet with low calories? And I try to explain to patients as simple as like, this is a chicken breast had 25 grams and only 75 calories. Nuts had maybe 15 gram protein, but has 700 calories. And it's all about your choices. And
I like the term protein dense, so the amount of protein per calorie. So when the challenge is when you're trying to get that 150
gram of
protein
a day.
If you don't seriously work at it to get that, you're going to do 3,000, 3,500 calories. So if you want to keep it near, your basal, your just the calorie intake required just to maintain your weight, it's a you have to work at it. Let's just say that. You have to be looking at the protein content of everything you eat.
Yeah. I will say, I feel like there's a bit of a common misconception when it comes to like protein dense diets. And then just like around the idea of just muscle mass, building muscle, because I feel like there's just a perception that building muscle is really more of an aesthetic versus actually functionally.
Agree. And it's really this is what we have been trying to change. Because even for me, it took me a while to change my all my thoughts about I always was a believer in cardio. And then in between 2010 to 2020, multiple studies showing how important is the muscle mass. And then again, I keep debating, is it like the VO2 max and cardio? Is it the muscle? I think both are the same. I will do the VO2 max a little bit more, but the muscle mass is huge for you. And then we see why people die on younger age and how their muscle wasting problem or the sarcopenia, it's causing them to not function. And that's where people who live longer, how we can do it. It's like with the good nutrition, good fitness, good social network, so there's multiple factors, but one of them, the biggest factor for us is have to have them a good habit from nutrition to fitness, and then finally my area, sleep.
Well, what about when you hear from people that you can do too much? So with that in mind, you can do too much cardio. So, my trainer's like, you got to be careful with that cardio because you're just burning the muscle off. You know what I mean?
Right. Yeah, I agree.
I don't know what's your opinion on that? Do you agree with that?
Absolutely not. Absolutely. You cannot do. So again, it's all about previously, we did not have smartwatches. We did not have a way to watch how's our heart rate, We did not have a way to watch what our muscle mass. We did not have a way to understand our nutrition and our protein. Now you are doing all informed decision. And that's where I don't want you just to do something and not to get the feedback about, are you benefit from it or do we need to adjust it? And it's like, I believe there's that too much cardio, too much weightlifting. I have ladies, they say, I don't want to build muscles. I tell them, don't worry about it. You're not gonna show. You need a lot of testosterone. You need a lot to build up muscle to show, but you really need a good muscle mass. And the same for cardio. It's just the debate, do you do cardio before weightlifting, after? And we can discuss it, but there is no right way and wrong way here.
So, Jean, do you agree or disagree that you can in fact do too much cardio?
So I see some patient, but that we're talking about 1 per 1,000.
Okay.
Okay. So if I'm talking about the majority,
phantom warrior.
yes, I'm not worried about that. I'm talking about people who they do with us road biking for 9 to 10 hours. I understand, but how many of our clients and our everyday patient doing it is extremely low. What we need to get most of our population. I always like to discuss the 80-20. I always try to give my recommendation for the 80%, and I will tell the 80%, don't worry. No, there's nothing called too much cardio for you. Just you build it up and you keep it a good habit. Now, some extreme patient with a significant muscle or low muscle mass on their DEXA scan body composition, I tell him, you need to do less cardio and you need to do more weight. And I had this in a young lady in her 50 a couple of weeks ago in my office. And I had to tell her, but that's again 1 in 100, 1 per 1,000 maybe.
Elephant in the room for elephant in the room for sarcopenia, testosterone replacement, like in men and women. Where do you land on that with the longevity?
That's that's actually becoming a big chunk in our practice.
Post-pandemic.
Yes, that is a huge. So it's really, majority of patients do not need it. Okay. But we do offer a tissue sampling with 24 hours of testosterone hormone evaluation. We do use multiple companies in the nation that they're really doing good with giving us an idea. And then I do morning testosterone blood tests, and the majority don't need it. Do I see patients that they do need it? Absolutely, but we like to use evidence-based medicine and not just to give it to any patient who's feeling tired. And I need a combination of blood workup showing low testosterone and symptoms, and that patient now working out. A lot of time, people who start working out and exercising, their testosterone go up. Their life get better. And with weightlifting and cardio. So we go back to the first step. It's that the reason why it's our first step is with wellness and exercise and fitness, because it fixes a lot of your problems, including stress, including sleep. So after we talk about fitness, wellness, and we talk about nutrition, our third pillars is sleep. So,
because if you haven't slept well, you're not going to feel like working out.
Absolutely not.
Well, I think
if you have worked out, you might sleep a little better.
Yeah, well, I'm glad that we're talking about this too, because I think about Kobe Bryant, right? He always talks about working really hard, and honestly, I think he's kind of an outlier because I can't imagine how he was really working out. But I don't think he was really getting that much sleep either, at least from a public perspective.
Yeah,
he always talks about he's waking up at 3 or 4 a.m., that he's going to sleep and still training all day. So, how important is sleep in recovery?
So that's very this is where I'm as you mentioned, I'm a board certified in sleep medicine. When I did my medical school, we did not have sleep medicine, okay? And then slowly in internal medicine, when I got certified in internal medicine, sleep started becoming a part. And then we did the pulmonary, and I have to rotate with neurology and do sleep medicine with pulmonary to understand it. And then I got certified in sleep medicine as a new branch of medicine. And the majority of cases I see, unfortunately, still related to being sick. People are sick, not sleeping good, snoring, witness apnea. They do the sleep test, the sleep apnea test, and then I see them. But the biggest part of our population issues are insomnia and sleep deprivation. Lack sleep. That is a chronic problem. So that's the reason why the pillars, and I always like to look at the big picture. And I'm going to keep going back and tell you where I am in that. So with the fitness, nutrition, and then sleep side, these are the three pillars. And then we're going to go back to the hormone at some point, because I think it's a supplement. And then the biggest part for us also the genetics testing and all that to help with all this area. So with the sleep, the majority of the cases I see, it can be fixed just with education, just with habits, the power of habits again. Do we need medication? Absolutely. But unfortunately, we overdo it in our country with medication. Majority of my patients, they need just to have education about their sleep, how to build a good sleep habit, and something had been broken for 20 years. People want to walk into my office and be fixed with medicine. And I tell them, nope, unfortunately, it's going to take some hard work. And sleep deprivation is a chronic problem in our country. And I don't think we understand the priority of sleep. As we need to focus on the priority of fitness, nutrition, sleep.
I mean, historically, there's been no priority toward it. And
absolutely.
Even in the field of medicine, it was glorified to not sleep. Yeah, it's crazy.
Yeah, and then, for us, when I did our training, when we did the 80 hours a week, it's like who wants to leave in their 20s? Like, no, that what we were wrong.
When I'm dead.
Yes, so let's talk about sleep. So majority of the cases I see for sleep are coming for not having good quality sleep. Having daytime fatigue, sleepiness, tiredness, not have enough energy to do number one, the fitness and wellness, not have enough. And then we get more complicated with sleep deprivation. They get depressed, they get anxiety.
Had more diabetes.
You increase the metabolic syndrome, and that's a big area we're going to talk about with chronic illnesses. And then we start building it issues after issues and getting medication and getting used to the medicine and getting dependent on medication. And then you have the huge area of supplement to help sleep. We go back. So here what I tell my patient, and I'm a big believer in that, it fixes around 85 to 9% of the cases. The most important thing in sleep, do you have any idea, Taylor? What's the most important in sleep? When you go to sleep.
To stay asleep?
Oh, yeah, it's like to sleep in general. Do you think it's your environment, your bed, what's the most important?
I want to say environment.
Okay, so part of it's environment. The most important is the habit. Going to bed at the same time and waking up same thing. As simple as that. You cannot believe how critical that. But it's so hard to do with our social life, with our commitment.
Yeah, try to get your spouse on that page.
Yes.
You know?
Well, I mean, my girlfriend's a night shift nurse.
Yeah.
So,
oh my God, yes.
I feel like she's kind of losing years of life just because she can't get back to the same circadian rhythm. And
yeah, she is young. So that's very good point. So the most important, let's go back to go to bed. So when I see a patient who's a nurse, they do night shift and they cannot change their life right now, I tell them, can you go to bed 7 a.m. every day and wake up at 2 every day? Even when you are off work, you cannot. So you have to stick with the same schedule. So I ask a patient, like majority of my patients, they are living on 4 to 5 hours of sleep. And this is where I like the wearable because I can get the data. I don't want my patient to be obsessed about it every night, but I like them to wear it. Give me the data for a week, 2 weeks.
So which wearable you like in these days?
To be honest with you, my number one is Apple Watch. Okay. It's have been the most accurate and the easiest and the most popular. Okay. Number two, and I have actually less I give to my patient that, okay, Android, Google, and then we go to Garmin. And Garmin is excellent.
What about the Oura Ring? Was that...
I like it. The problem with they have a membership, they have excellent data, but for me, it's easier to deal with data, with the heart rate, and we can talk about HRV also. HRV is a very good number. I need you to know it. Okay? So we go to the sleep pattern, and I like to see them going to bed same time, waking up. So I get patient, but seriously, yesterday, I had a patient, he's telling me they go to bed 1:30, 2 a.m., and some days they wake 6 a.m., sometimes they wake 4, they want sometimes. So I tell them, okay. So I design a reasonable program. You don't want to overdo it. So, and I restrict their sleep to start with. I tell them, I need to go to bed 1 o'clock, wake up every day at 6:30. That's it. This is the first step. And if you're going to wake up in the morning, you're going to say the first night, oh my God, I did not sleep at all. I'm sorry. You make it a bad night, you don't make it a bad week. You don't take naps. I'm okay with you caffeine in the morning. You stay tired the first day. You get you don't go to bed earlier. We've talked about 1 a.m. to 6:30. You stick with 1 a.m. You push through. You push it through a few days. After you start giving me, in a week, 2 weeks usually, it takes that much time. And that's where people get tired and start napping and start taking caffeine in the afternoon. No caffeine after 12. No, and caffeine can stay in your system for 12 hours. Yes. Okay. You see, it's a small habit. So if you take a lot of caffeine, by 4 p.m., I tell you, try to take it by 2. Then slowly take it by 1. No Coke. No, if you want the tea, get like tea with like caffeine free. So it's small, tiny change in habits. You're not going to be a magic switch. You're not sleeping for many years and you get, so we restrict your sleep first. Sound good? That's the first step. Yeah. Let's get a little bit more complicated. I have rules, I call them 4, 3, 2, 1 rules. 4 mean 4 hours before bed, no workout.
Right.
Workout all day. But I don't want you to stress yourself and your muscle and your adrenaline up.
Cortisol.
Yeah, cortisol up, all that 4 hours before bed.
Okay.
3 mean no food 3 hours before bed. Okay. Yes.
Yep.
So if we say midnight, you're going to bed, I'm going to say 8 p.m. you stop working out. Nice hot shower if you like, an hour, 2 hours before, but no workout 4 hours. 3 means 3 hours before bed, no food. Okay? People like to snack, and that can cause acid reflux and cause a problem, and then can cause interruption in your sleep. So I'm taking that part out. 2 means 2 hours before bed, no drinks.
Water, no beverages. Yeah,
Yes.
Is alcohol the 5?
Man, but alcohol. I will talk about alcohol. Alcohol is another big issue because it's alcohol is #1 medicine in the United States for insomnia. We use alcohol as a first medicine to help us with insomnia, and when I show patients their data,
right,
and I'm going to talk to you about home sleep testing later, and I show them that alcohol get you into sleep, but it's kill the structure of your sleep. It damages the structure of sleep. So you don't get to the non-REM stage 3, and your REM is going to be all interrupted. It's crazy. So although it gets you to sleep, so I tell my patient, so I'm including alcohol with drinks and 2 hours before, but it's not, I have a different session about alcohol. And again, when I try to change patient behavior, you have to be patient. You have to really do it step by step. A lot of our patients, they get overwhelmed. I agree with them. It's not doable sometimes to do all the changes at the same time. So I say 4, 3, 2, 1, 2 hours, no drink. But if you need to get sips of water, I'm okay with you if you need to take your medicine. Now, 1, the hardest to do.
No screen time.
No screen, no TV, no phone, no light exposure. And I keep telling my patient, you're an airplane. You're landing. Did you ever see an airplane land within a minute? No. 30, 45 minutes. You have to slowly go down. You have no light exposure. Read a book. Ambient light is fine. Audiobook. Podcast is the best to listen to. And if you need to read a book, read a boring book. Please don't read something interesting that's going to keep you attached and you want to finish it. So I always suggest medicine. As like for people who's not in medicine too, like something that you can read, get you down with ambient light. And then you start going to bed 30 minutes before. The room had to be dark, cool, as cold as you can take it. It's better, but the dark room is critical. And all these simple stuff from good pillows, the beds, and people want to invest money because they believe it's okay, wherever you feel comfortable with.
So my patients tend to swear by those cooling beds.
Mm-hmm. Yeah, I think getting the room down a couple of degrees and have it warm up an hour before you go to bed. So these are good. I don't want people to feel that they have to put an investment before changing their habits. It is worth it for the final stage in us building the good sleep habit. Now, after I get the patient, to sleep only 5 hours or 4 hours. It depends again on the patient situation. They sleep 5 to 6 hours. Finally, I get them. I see them 2 weeks, 3 weeks. Every 2 weeks, I give them 20 more minutes, either before or after. So they can build it up, because we do need the 80-20 or the 99% and 1%. We really need the 7.5 to 8 hours for longevity.
80-20 meaning like 20% of your actions go to 80%.
Yeah, no, for me, I do that in the other way. I try to control, give advice for 80% of patients who really need the 7 to 8 hours.
Gotcha.
And the 20%, yeah, sorry.
Of course, I get the odd patient that says, "Oh, I think I have that short sleep need."
Oh man.
And of course, you check.
No, they don't. Majority of people don't. I mean, I think some of the biggest leader in the history of a human being, they had that gene. They were functioning 3-4 hours of sleep.
Churchill or Clinton or whatever.
Yes.
Hypomanic.
Yeah, they did, but it's not common to see that type of gene in our population, and that's where I say, please try to get me 7 hours sleep. And again, it's gonna take months and months to build it up.
Now, what about the people that drink, like right at, let's say after dinner, right? They offer an espresso or some coffee. Like I have my parents and family members that like drink coffee. They swear by saying, "Oh, we go to sleep."
So I tell my patient first, switch to decaf. You like the shot, you like the taste, switch to decaf. Okay? To the best of our knowledge, it don't work. It will work against you. You need to build it up. So, and this is where we talk about supplements, and that's where people start talking about supplement and medication to help with the sleep. Majority of my patients don't need anything. They need the
magnesium.
Okay. So I tell some of my patients, if they have magnesium deficiency, or if I test them and they have, do I give it? Absolutely. If patients are not, I tell them it's okay not to worry about it. Some people swear that it helped them. We don't have good evidence, but it's okay. The same for, so actually, let me talk about medication here, because one of the medicines which I really like is doxepin.
Oh, nice.
For sleep maintenance insomnia. So doxepin is a medicine that we used to use 10, 15 years ago for anxiety, and we used to use 300, 600 milligram.
Right.
And we found out that 3 to 6 milligram for some patient an hour and a half before bed can help them maintaining sleep, don't have side effects. If you see the side effects, every side effect reported for the high dose medicine. You're not going to be dependent
on high dose is like
300, 600.
And we're talking about literally 1, 2, 3 milligrams.
Yes.
Oh, wow.
Yeah. So actually,
and make it. I mean, how they get?
So they make the 3 milligram and the 6 milligram, but unfortunately, it's a new medicine, so it's expensive. So we found the best medicine for majority of patients that is very, very cheap, cost them $20 a month, is 10 milligram capsule, because they made it in the old system. So 10 milligram for majority of patients good. Don't make you dependent on. It can help you building that maintenance sleep. And then we need to
talk about trazodone.
Trazodone is my second choice, honestly, but at a lower dose, 25 to 50, not higher, not 150, not 200, not the depression dose. 25 to 50 will be my second choice. Now, do I give any of these medication like Ambien, CR? I do, but patients have to know it's a short term. Have tons of side. I know. Yeah, exactly. We cringe when we see. Oh my God, we cringe when we see. This is not the right thing to do.
Oh, I know. Yeah, we've all heard the stories. Yeah.
Oh yes.
People that take Ambien and
and the side effects and the increasing risk for dementia, increasing risk long term
in accidents. So they get up
and hallucination at night, especially elderly patient. So there is all of us. We travel. I travel a lot to Europe and Middle East, and jet lag is an issue, okay? So treating jet lag, so I explain to patients how to treat jet lag, how to see it, how to get the timing in Dubai, like now, and adjust your life, depend on that slowly. So
there's an app that helps with that.
Oh, I didn't know that.
Time Shifter.
Nice, okay.
And so in the days leading up to the trip, you'd change Yeah, the timing of your caffeine consumption.
And this is honestly what I've been doing for years. And I'm blessed. I like go there, get to it's the first day, it's always hard, but stick with it. Stay awake all day. So at the same rules which I'm doing here, I'm doing when doing the. Now, there's something I call social jet lag. You're traveling, you're visiting family, it's okay. And my friend, they go crazy because we are up until 2 a.m. enjoying, catching up, playing cards, and I wake up second day 6:30. That's it. I'm going to wake up same time every day. If I'm going to give myself half an hour or if I give myself power nap, this is the only time which I use an alarm. I put an alarm and I sleep only 10, 15 minutes if I have to. So if I feel I really need a nap, I'm okay with the nap. Take it as early as possible in the day, but 10, 15 minutes. And the first few months when I'm treating a new patient, I don't give them this option. I build it up. And this is where we go back to precision medicine and personalized medicine. And it's how we can give each patient different recommendation, depending on their situation, depend on their family, depend on their lifestyle, depend on their work hours, depend on what they do and what they do. And this is where how we build it up to have a long-term relationship where you can keep giving like a step by step. When you see a patient and give them all these recommendations, same time, it's overwhelming. It's like, you see what I mean? But when you do it with them step by step and give them the week by week and just build the habits. If you don't build a habit, you're not going to benefit from something.
What I think is like really fascinating about all this is these are all actionable lifestyle interventions, right?
Agreed.
In kind of going back to what you mentioned where it's like, oh, patients say, I think I have the gene for this. Is that a common response that you always hear from patients? Where they try and justify that they have a genetic predisposition for their actions?
That one's a little unusual, I would say, I've only gotten that a couple of times, but I think to the way genetics and looking at single gene risk and polygenic risk for these diseases, and kind of how this conversation started out, you see where the person has risk. You individualize them, you personalize them, you look at what their genetics are, what is the lifestyle, what are the problems, where are they going to sleep, what are they eating, the anthropomorphics, put all that together and you analyze it, which is what we've been kind of doing manually in our practices. And what often it boils down to things like cancer, well, how can sleep have anything to do with cancer? Well, if you don't sleep, you're going to be more insulin resistant. If you're insulin resistant, you're going to be overweight. If you're overweight, you're not going to sleep. And so they figure, I don't know how I say they, the ethereal they, that 50% of these chronic diseases would be entirely preventable just by getting those basic lifestyle things that Blair's talking about. The sleep, the nutrition, avoiding ultra processed foods, not being overweight, avoiding weddings with added sugar, eating, cartoon dense, kind of food.
And it's very good point that people who live to 100, for them, it was more avoiding the chronic illnesses than treating the chronic illness. So to live longer, you really need to prevent the chronic illness. I know our system built on treating after you get it. And this is where I used to joke with my friends 10, 15 years ago that we need to change our system. It's not health system. It's sickness system. It's like you get sick and then I will see you.
Sick care system.
Yes, instead of healthcare system. And this is where we're trying, and this is where it was the magic for me reading a book like Outlived by Peter Attia, because it was all about prevention, about living longer and preventing the disease and catching early sign of that you have high risk for this illness. And this is after we talk about the pillars, we go to about the chronic illnesses. And this is where we do in our practice, we start. People ask me so a lot of time, what are your favorite tests? What do you, and this, I used to do it for my friend, my family. They're not my patient. They are not seeing them for lung diseases or sleep medicine or in the ICU for critical illness. So they ask me, my nurses, like, okay, what do I do? I tell them, okay, get me insulin resistant. Let's be sure that you don't have any pre-diabetes, and get me lipoprotein little a.
Sure.
Get me ApoB, lipoprotein B, to see what's your cholesterol style, what's your, not the LDL, with all respect, I do believe these tests are more accurate. I used to ask every patient to get me ApoE, which is a gene test to see what their risk for Alzheimer. And then I do other like liver enzyme and other stuff in general with even sometimes like fasting glucose. But these are my main tests to do. And we start building up more and more genetic testing that I'd like to do, like BRCA1, BRCA2, other like metabolic related genes. And so I start doing it list and give it to my family, my friend, and then we start the practice, and now we do it more organized way. We do the testing, to catch early sign of chronic illnesses and give an action plan to prevent it. And a lot of time, the action plan goes back to the same pillars. We have to fix the wellness. We have to work out. You have to lose weight, but like in a good way with good nutrition. You have to have the high protein diet, and you have to have good sleep. And so we go back to, and then one of the chronic illnesses is obstructive sleep apnea, which is extremely common. And I did practice years in Hawaii. And for me, in the Midwest,
Yeah, there must be a lot there.
it was a great, man. I worked with Kaiser Permanente. I had great experience. I worked with the Queen Medical Center, and it was great. But it changed my mind because I always here in Midwest, I associated obstructive sleep apnea with being overweight. And then I had more Asian population, and I was wrong because a lot of young, skinny patients with their genetics, they did have obstructive sleep apnea that people thought, it's a snoring. It's like, and it's a problem with like, it's just sinuses, allergies. And when we start doing more and more testing, we did catch more and more sleep apnea, and we start treating the chronic illnesses. And obstructive sleep apnea is extremely common in men. It's all about our anatomy. It's all about the upper airway collapsing and closing down and stop breathing.
That soft palate dropping down.
Yeah, and then we try to fix it multiple ways. We try to fix it by losing weight, by surgery, and unfortunately, the best gold standard still CPAP therapy. So I get a lot of clients, not they're coming in their own because of their significant other. Significant other. And is it like hearing this snoring?
I mean, no, it's right intake question. Do you sleep in the same room?
Yes.
Your significant other.
And why is that?
And as soon as they say no, you go, why? Well, because,
Snoring, witness apnea, and then go ahead.
Well, I was just going to say, then that person needs to be tested.
Yes. So so 15 years ago, we used to do the test in the hospital, in lab sleep studies. And then 10 years ago, more than that, honestly, we start doing more home testing. And they're very accurate. The majority of patients don't need to have the in-lab sleep study. We can do it for you in your home, in your environment. And you know what? We're going to test you while you're here. Okay. It's a really good knowledge. Right?
Yeah. I mean, we can talk about it too. Yeah. I mean, we even did our, we did my teen-enabled blueprint.
Oh, good.
Yeah.
Great.
We posted on the podcast.
Oh, very good.
It'd be really cool just to
It's up to you. I will be glad to have a follow-up podcast with you about just a sleep study, because people don't understand how easy to do it now. How cheap is it?
Yeah,
and
talk about it.
And to be honest with you, like even a lot of my clients, I tell them, don't go through your insurance. Your co-payment going to be like $250. We can do the test for you for $250. Just as cheap. It used to be $5,000 many years ago.
Wow.
And now we get, with our test, we get any nocturnal hypoxia, any low oxygen at night. It's an FDA-approved device to detect AFib. And we do the sleep apnea, and we measure how many times your airway collapse, upper airway, and is that snoring or true apnea or hypopnea, and then we calculate it, and it depends if you have
So how are you measuring respirations and?
So the device, it's a smart like a band with oxygen and muscle movement on the chest.
Okay.
And we have
a sensor.
Yeah. And it's very extremely accurate in doing it for many years. And I kept doing the first few years, I kept doing the in-lab sleep studies because I was skeptic, like, no, it's a new technology. And I was absolutely.
You're all in now.
Yes, absolutely. It's very accurate, very easy. You do it in your bed, in your environment.
What's the name of the?
Well, we use WatchPad, and it's there's multiple companies, Watermarks, and there is ResMed. They have one. So there's multiple companies, but the WatchPad is the easiest for us to use, and we have a disposable one, and we have the one which we use on a regular basis in the office, and they are. And we can send it to you by mail, and you connect it to your smartphone, and you don't have to return it. It's one-time use. Then within 24 hours, I can tell you if you have low oxygen, if you are running low oxygen, you have sleep apnea, and how to treat it. Now, that's the biggest problem. Like, we don't treat every sleep apnea.
Right.
So if you have a mild sleep apnea, I'll tell you just do this 1, 2, 3. Sometimes we do positional therapy in bed, because your sleep apnea works in your supine sleep. Sometimes we tell you just like get the head of the bed elevation, sinus treatment sometimes. It's very simple. But if it's moderate sleep apnea, or if it's mild and you have comorbidities like significant high blood pressure, coronary artery disease, risk for stroke, absolutely recommend treatment. The best therapy is still CPAP. And that is also another habit that we work with our patient to get used to it if they need it. Because I remember when
I love my CPAP.
let me tell you, I have a gastroenterologist patient. He was funny, very smart guy. He first, before I gave him the machine, he said, it's not sexy to have the mask on. And then 4 weeks later, he came back with good energy, feeling good, had the best sleep in his life. He said, I think it's very sexy to have the mask on. So it's like, it's fun. We have a small mask, bigger mask, and we use like a third part company. We don't sell the CPAP. We don't want to go in this business, but we give you and you can go through your insurance. You can buy your own.
And there's the AutoPAP now.
Yeah, the AutoPAP is the best. And we give it, so the upper airway collapse. So you're not moving air. So the heart and the brain think, oh my God, we're drowning, we're underwater, we're not getting air. So the heart starts going fast. And the brain wake up. We call it microarousal. You don't remember it, but if it's happened for you 40 times every hour, oh my, we have numbers as high as 150 times an hour.
It's crazy. And unless you measure it, you're not going to.
So, and whenever you get that many times you stop breathing and microarousal, the heart keep going. And you know what we call patient with the severe significant sleep apnea, we call them non-dipper, because they don't dip at night. Their heart don't rest. Their heart rate don't go down.
Right.
So they keep going.
Yeah.
Year after year, you can do it while you're young. You reach 60, 78, and you start having heart failure. You start having significant high blood pressure. Secondary, what we call pulmonary hypertension, elevated pressure in the right side of the heart. So we give the CPAP, the upper airway open up, okay? And it's just a pressure air. It's like you're driving on a highway, stick your head out. That air pushing your face, that's what we're gonna open the airway. And then you're gonna get air. That's the job of the CPAP. Because we tried to fix it by surgery, we could not. Sometimes we do oral appliance for mild sleep apnea to open it, but it's second choice after CPAP.
I've had great luck with those.
We had some cases. My brother-in-law is like, he hated me after I gave him the CPAP. He could not do it. But when we did the oral appliance for him, and these are expensive, and we were able to get him a deal that it's insurance, the medical insurance will cover it, not the dental insurance, through a certified dentist. But I had to be certified dentist. It's a second line of therapy for mild to moderate sleep apnea. And that where we treat it, and we do see, I mean, we have great cases. Like, you cannot believe people how much they love their CPAP. It's a love-hate relationship. Again, it's something new, another new habit. You travel, you take it with you. You're like gonna have to take care of it. You have to keep it clean. You have to change the air filter. So we treat the chronic illness, I see a patient once in 3 months for the insurance purpose, and then once a year. And I like to see the CPAP, and every 5 years we get them a new CPAP. Treating the chronic illness is a huge. Catching the sleep apnea early also is a huge to treat it early. And we do see great cases. So I thought like, 85 is old, I should not give them CPAP. And I was wrong. Yeah. I have a patient, they're 90s now, 93, 94, they use their CPAP and they love it. Age is not a factor anymore. And you know how we defined old now?
Functionally for me, but
it's always my age plus 15.
Oh.
So that's the joke that we say, like, when I'm a 90, old gonna be 105. So I will never be old.
Oh, that's a good one. So how do you incorporate heart rate variability?
Very good. So that's where when we start with the wellness, and I suggest a smartwatch, and I depend on the patient. The reason why Apple Watch #1 for us, because majority of patients have smartphone, which is the iPhone. And then second, it's the easiest way to work with patients. They don't need that much work. Their grandkids can help them to set it up first time. And then do you mind if I show you your HRV? Do you have your phone on? Yeah, it's up to you. Yeah,
I do. Yeah, no, that's awesome. So it's all over the place.
Yeah, you're good. No, but
I had one the other night that was like crazy. It was like 18 or something.
Yeah, So you go to health. So in the iPhone, you have Garmin's. Garmin's great also, but a little bit more complex. Yeah. So you go to the corner, you browse. Yeah. So if you don't mind. Yeah. So I'm going to show you with the browse, you go down and then you can go to activities, body measurement, hearing, heart.
And so we go to heart. Again, all this from your patients into your clinic, you have some kind of setup with Apple.
Yeah, we're trying right now. What we're doing right now is patients send me a report. A lot of time I tell them, just bring the phone with you and always see the data so I can show you. Yeah. So when we go to the heart rate variability and we try to to measure the variation time with the intervals between the QRS and the heartbeat. So I like to see the month.
Yeah.
The HRV, when you see it a day, doesn't make sense. So but you see how it's up and down, and I can tell you were stressed here.
Oh yeah.
You see, like this week here, you were stressed. This up and down is good. So let me explain it to you now. So HRV is the balance between parasympathetic and sympathetic system. That we have a nerve system that when we call fight or flight, when you work out your stress, your heart rate going fast, you're going to fight or you're going to run away. And the other system is your rest and digest. You're going to be resting, sleeping, recovering, your heart is going to slow down. It's life. It's going to be a balance. I want you to work out. I want you to be stressed. It's okay. Some stress is good for us. Okay? When you're working out, your heart is going to be fast. The heart rate variability going to be very, very low because the heart is going fast. The intervals are short. If you have good sleep and resting good and able to get your stress out and you're able to get your mind clear and the HRV will be high. And that variability, what we like to measure and see. And we can catch early diagnosis for problems like insomnia or not getting sleep, or like I had diagnosed a case which was weird with severe acid reflux. The patient did not have heartburn, but they kept interrupting their sleep and they're not resting well. And we connected to their food and we give them PPI. The second thing, they're just sleeping much better. Like simple stuff. This is not the common, but we catch in very interesting cases with HRV. And it's one more tool for you to see and measure, and you don't need to be obsessed about. It's just one more thing to trend and to get a better idea about your vital sign, your knowledge, your feedback about how you're doing it, and then you adjust depend on it.
And so when you're looking at it like over the course of a month, do you have like goals for patients where you go, we're trying to get you to 35?
Yeah, so the goal, the absolute number mean nothing. So you can compare your number to my number, okay? But for you, I want to see, was it the weekend? Was it like your Thursday, Friday, the most stressful time? Or you're traveling and you see, and then is it like maybe we start talking about your sleep, about your resting, about your recovery. Maybe After workout, you're not recovering because you're not staying hydrated. Maybe we need more supplement like creatinine, and that's another thing we can talk about. And so there's a lot depend. At a lot of it is just lifestyle modification, and understand that maybe this is causing you a lot of stress that day of the week, that day you're not sleeping good, or whenever you're drinking alcohol, or whenever you're like eating, but a lot of it is just a small modification. Sometimes we catch other issues. So if I have the patient have persistent low heart rate variability, I get them 12 lead EKG. I tell them to get me, like whenever their heart rate up, with the smartwatch, you can get the EKG now, one lead. They send it to me, and we did catch AFib in a patient. So you can catch these early. And this is where I like the smartwatch in general, where the Apple Watch can give me now, if it can detect high blood pressure, it detects early sign of obstructive sleep apnea.
How's it detecting high blood pressure?
So we don't know exactly. Apple, they just announced it 2 weeks ago. And
Is this just on the latest?
In the latest, but it's actually go back even to the older watch. I think it's a software, and they did not disclose exactly how they're doing it. But it don't do in the actual daily measurement. It give you sign. We think it's more depend on the light and the artery with the spasm, and then the muscle movement, and then the heart rate. But don't quote me on that. I'm not sure how they're doing it right now. But they detect the sleep apnea with the low oxygen and the heart rate variability at night. So they can give you the trend to suggest that you have obstructive sleep apnea. And we start getting patient their watch, but you have to use it at night. So you have to charge it maybe in the morning while you're in shower, and you have to use it at night.
My patients. So it's we think a lot alike. So some patients go, oh no, I charge it overnight. So I think I'll charge it in an hour. He's still in the shower.
Wake up in the morning, have it there. I like to see the resting heart rate also. It's give me a lot of information about my patient. If their resting heart rate up, I had patient was showing hyperthyroidism, did catch it. We do the thyroid function test. We do some, as I told you, hormone evaluation, including the testosterone, estrogen for ladies, and we do all including thyroid function. And we sometimes as easy as seeing patients have persistent high resting heart rate. When you wake up with the best heart rate and where you are. So a lot of data, how to use it, the most important, don't be obsessed about it. It's not a snapshot. It's the trend. It's where we are and how we can get better and how do you use it. It's great to see the steps, as simple as that. I ask for 5,000. It depends on the patient. We start 4,000, 5. I keep going 7. Patient don't trust me after that. They said, you told me 7,000. I told that was at that time. Now our goal is 10,000 steps. So you always have to have the goal. If you don't have goals and reasonable goals, you cannot achieve it. Now, if you walk 10,000 steps, I'm not going to talk about steps with you. I'm going to talk about
something else.
Cardio, like zone 2. If you're doing zone 2, I'm going to talk to you about zone 5. And I walk muscle mass. And so it's just, again, a step-by-step approach. Going back to the habits, the power of habits is amazing. And how can you get it to the next level with your care? And that's the chronic illnesses. And then we take it from the chronic illnesses. The most important for us, honestly, is metabolic disorder. It's like the insulin, the A1C.
Yeah.
As you know, they taught us in school, and still, that A1C 5.9, pre-diabetes, don't do anything about it.
Not always.
Yes, I agree.
You know what's interesting? Just a brief non sequitur. So I have a couple very uber healthy patients. One of them's my wife, actually. And one of them, very thin, watch everything. Card never crosses their lips. Nothing but cardboard, solid, and A1C is like 5.8. Do you know why? Well, I hazard a guess why.
Why?
Low oxidative stress, the red blood cells must last, 20-30% longer than the average person.
But I do the insulin level for these patients, and I want less number. But the majority of patients, if it's 5.8, they have sign. A lot of physicians don't like to treat. Honestly, I changed my practice over the last year.
I thought you're freestyle Libra there.
Yes, absolutely. I give it to my patients. So I like my patient to have, again, the education. So what we do, so we, like, this is an example. We use different companies. We connect it to your phone, continuous glucose monitor. I like every patient to have the knowledge about what they eat, how to reflect. It's more information, and it's actually change your behavior. After you see the ice cream bring your blood sugar to 300, 400, you're going to cut down the ice cream. When you see how much the food, the good food, and you see how the protein bring your blood sugar up slowly and bring it down slowly, comparing to the sharp rays with the carbohydrate, you change your behavior slowly. Yeah. So I like to give it to my client and get them the knowledge, especially if they're A1C, if they have pre-diabetes and clear sign. I treat it. Actually, I treat it with metformin, and my goal to bring it down to less than 5.3. That's my, it's not a regular goal, but I tell my patient, why not? Like, you're here, most of my clients are super smart, educated, and so my expectation for them, not just to be above average, why not go into the elite with the VO2 max? Why not getting to the maximum muscle mass? And why not getting the 8 hours of sleep every night? Our goal, it should be the best.
Do you focus more on fasting insulin and fasting glucose or A1C?
To be honest with you, so I like to measure all of them, but the fasting insulin the most important for me.
Yeah, same.
Yeah, it's a way but I do all of them, and I like to get my patient educated. And then when we do the hormone evaluation, we do see some weird stuff. Like sometimes we see a lot of our professional client, they have increased cortisol at night, evening. They peak. And that's not going to help you to sleep. That causes some insomnia. So we don't have a medication to help. So that's the only time when I really support supplement, which is like ashwagandha.
Yeah, ashwagandha is great.
It's great, but we give it to our client. We tell them we're going to rotate it 4 weeks on, 2 weeks off. And they see significant improvement in their sleep. But we need the knowledge about the hormone evaluation, which is the last area. And part of the hormone also, we're having more and more clients doing the GLP-1 therapy. So GLP-1 therapy finally got approved by the FDA to treat severe obstructive sleep apnea. And that with the goal of the severe sleep apnea that going to have the weight down, it's going to improve your severity of sleep apnea. But it's not, and most of the time, not going to cure sleep apnea.
Right.
So we kept debating about the GLP-1 therapy for weight management. And my approach for it, that unfortunately we're doing it wrong. I'm a big believer, it's a great medicine, but it's not the medicine by itself.
No.
So we try to do a contract with our patient. We're going to help you with the GLP-1.
It may be a disaster in terms of sarcopenia.
Thank you, yes.
Yeah,
the muscle wasting.
It has to be coupled with significant effort to add muscle.
Absolutely. So it's a contract with our client.
Or you get the aesthetic manifestations. Also, how they say Ozempic face and whatever. You don't get that if you're working out.
So our agreement with our clients, we're going to provide you with GLP-1 therapy. I like microdosing it. With all respect, I believe a low dose work very well with no side effects.
Yeah.
And we are more patient with our client to just give it more time. And then my goal is just 1 pound per week maximum. I don't want people to lose more weight, but the contract is you have to work out 3 times a week, weightlifting and cardio, and you have to have high protein diet. And we have to do a body composition scan before we start, 3 months, 6 months, so we can see the problem with the GLP-1 therapy. You're going to waste muscle and fat. And our goal to lose fat, not muscles. But people who don't work out and keep maintaining and have a better diet, they lose significant muscles. This is where we're talking about the Ozempic phase. You can see people. So if we lose it slowly and work out in the gym on a regular basis, that's always a huge, where people really see benefit. And our goal is around 25 to 35 pounds a year. People have to understand, we do a blood workup. We like to check pancreas level always. It's very, very rare to cause issues, especially with the lower doses. But we like to be safe.
You measure pancreatic enzymes in the stool?
We do it actually so far in the blood. We're going to be adding it. So what we'll just do the amylase lipase, and we try to do the sometime like with the liver function test, absolutely for every patient. And every patient get continuous blood glucose monitor. And if they is part of the contract, if they want more, we give them prescription. If they want to continue to monitor their glucose. And we want them to have good sleep. We want to see their smartwatch data and help them. Some patients, they are premenopause, and we start talking about other part, which is the hormone replacement therapy. And our biggest part we have, which is like what we added with you guys in the last year, is doing the genetic testing. And that seriously became like one of our biggest like package to help patient client long term, is doing the full genetics evaluation for them.
I was going to say, well, this controversial topic then, like from a patient perspective,
yes,
is I think with patients, we have all these lifestyle interventions. Yeah. So let's say we do the genetic testing and we get an idea of like our risk for chronic illnesses. But I think there's also a fear that they're just going to get the same recommendations or plans. That's like, why am I going to pay for this if I'm going to get the same plan if all of this is lifestyle interventions? Then it's like, how much does it really differentiate?
So if you ask me 5-6 years ago, I'll tell you, we did not have a good products to do genetics testing and to do precision medicine at that time. Slowly, we are getting where we can customize and do a precision recommendation, right, and made it simple for clients. It is like the amount of data. Like when I tell even other physicians that we can do a whole human genome, it's like, are you serious? No way. I was like, yes, we can do it, and we can do all these gene mutation, and we can do this, and we can do the monogenic risk and the polygenic risk. So it take them to the next level where, oh my God, so I really can do a game plan for my patient.
Right.
I can do a roadmap for the next 25 years for them. I can do the pharmacogenetics. I can do the medications. I can do the nutrition. So we take the whole big picture, which I was explaining to you, and we take it completely to the next level if we can do the genetics evaluation first.
Because you honestly can't do everything to everyone all at once.
Yes.
Right.
And so there's, it's kind of like seeing an increased risk here, and you just kind of put your thumb on the scale there, and you're just putting your thumb on all these areas of peak risk. But in order to know what those risks are, you need data. We're entering a time of totally data-driven medicine that leverages AI to look at that data and help you figure out which of these incremental changes need to be done, how aggressively, and which person at which time. But your point's well taken. I mean, one of the things we're learning about this is that sleep, nutrition, exercise, so much more important than we ever thought. Certainly when I started medical training, I don't know about you, I got zero training in sleep, 1 afternoon in nutrition, and 0 in fitness. 0. I mean, stone cold 0.
Yeah. Still until now, honestly, still like even they're doing more, but it's nothing enough. Like most of my education about it, it's actually personal effort, and it's like, and learning on our own and going to conferences. And now we are talking about few organizations finding in the United States focusing on this. And longevity and anti-aging, it's there. We're not there yet, but it's getting there.
It's funny. I was talking to a young woman that is in her first year of medical school. She goes, "Why are you telling your patients to take supplements? They're just peeing it all out." And I'm like, oh my God,
Yes,
that's what they told us 30 years.
Yes,
And
it should be real.
And so I go, I have an idea for you. Why don't you just go to Open Evidence?
Yes,
I go,
brilliant.
Open Evidence, go to Open Evidence and say, is there any, sound peer-reviewed evidence that supports supplements? And of course it's, yes. Right down the line. I go, well, but it is amazing. There's still minimal.
And it's the funny thing, which like I had the same with Nicasure, and they said, no, they don't want us to believe in supplement. I said, hold on, okay. what's the difference between supplements and medications? Supplements are medication, but they are not FDA regulated. And that's where I need my patient to be aware of. If I have it in a form of medicine, that exact dose, maybe I'm going to give it to you. But a lot of us, we don't. There's every patient about supplement talk is like, okay, please take vitamin D. Please take like some omega-3.
Yeah.
Creatine is great supplement for muscle building, muscle mass, and now for cognition, and even the 5 gram a day if you can take it. So magnesium is not a problem. So there's some supplement are really ashwagandha for some patients are life. It's a great medicine, a great supplement. So, but supplement are medications, but
You
they're
can't
not.
give everything to everyone.
Yes.
So there's still this personalization, individualized thing where you have to understand that patient.
This is where like you guys like with your idea and your like how we can do the genetics testing, how we can understand. Like I had a client a couple of weeks ago where we show him with his gene testing, we showed him why he need different vitamin B, methylated vitamin B, and why he need this. It was mind-blowing for him. I said, oh my God, I've been taking vitamin B all these. Nope, unfortunately, don't work for you.
Yeah.
And then there's the same, like I showed him his information with the ApoE. And unfortunately, he's positive with the 4/3. He's high risk for late onset Alzheimer. Within a week, he changed his behavior. He stopped drinking.
Oh, yeah.
He's hitting the gym more regular. He's having more sleep. It just, everything I told him about Alzheimer, I told him, man, unfortunately.
Was this patient?
72. Yeah, 72. And he
that kind of behavioral change also in 30
and he had been drinking all his life. He quit. It's impressive.
I was looking at you. No, I'm just scared. I don't have it. I luckily know. I know.
Well, so
still,
and again, I had to explain to him. Even for him, he's a great guy, very very smart. Genes are the guns, and our environment, our behavior is what triggered these guns. It does not mean it's a death sentence. No, you can change your behavior anytime and have a better quality of life.
These chronic diseases have 20, 30, 40-year runways. I mean, so the average 30-year-old doesn't realize they have atherosclerosis, right?
Yes.
And if you want to live in those magical times, which we haven't gotten into, we got another one is about what medicine and aging and longevity is going to look like 30 years.
Yes. Believe me, you have no idea.
5 years from now, it's amazing. It's amazing how much it changed. And this is where
it's
becoming
accelerating.
Yes, it was a hobby for me a few years ago. Now I want to do it and I want to keep going and I'm learning. I was explaining to you how many courses I'm doing in the next few months and then doing exams and stuff that it is medicine MDs, DOs, they really need to take over and manage patient with the longevity. I think we have a great opportunity to do more prevention, do more and make it a true healthcare system where we can prevent chronic illnesses and we can help people stay away from doctors, as I say.
But since we're set up, the whole sick care system is set up over episodes of illness because that's where rehabilitation comes from.
And for sure.
I liked what you said before about just paying cash for the sleep study instead of.
To be honest with you, yes.
And there's so many areas of medicine that are like that now. Imaging also, you pay the cash plus and imaging.
For calcium, I tell every patient, please get calcium scoring CT, the DEXA scan, and they are cheap. So one last example, and it's my area as a pulmonologist, we do low-dose CT scan of the chest for cancer screening for lung cancer, as lung cancer is number one cause of death in cancers.
And 15% of lung cancers happen in people that never smoke.
Yes, so that's where I'm coming to my next point. Number 7 cause of death is lung cancer in non-smokers. So for $250, $300, I'm not sure how, even now it's $190, you can do a low-dose CT scan of the chest. Yeah. People who smoke for 15-pack year history, we do it for them between age 50 to 80. But honestly, now I do a gallery test where the 50 different type of blood testing for cancer, for screening. Also, I recommend for any one of us above age 50, even non-smoker, to get a low-dose CT scan. Low risk for radiation, very good information is number 7 cause. I recommend colonoscopy for every patient above age 45. I do recommend the low-dose CT scan of the chest, especially now with the vaping.
You're saying for every patient?
For every patient.
Wow.
Yes.
That's the only one doing it.
Yes. Yes, seriously. That was changing my behavior. So that's where changing my, like, okay, with the everything.
You come to that just logically.
Yes.
I mean, there's guidelines and then there's common sense.
Yes. And common sense comes from practice. Yes.
Yeah.
It's not I mean, again, I tell my patient, I think about this stuff 1,000 times a day. Again, I'm not going to judge you if you don't, like, you think about it once every 6 months. But we have to get the bridge to understand where I'm coming from. Where is my condition coming from?
Wow.
Can I ask one more non sequitur question? Or
Yeah.
how about you hear about the mouth tape?
Yes.
Yeah. Where are you on that?
So I don't have enough evidence to support it, but
You do it.
I don't.
I do.
Okay, no, let me tell you, if I have a CPAP and I'm using a nasal mask,
Yeah.
what I will do, I'll give you a chin strap instead of the
Is that better or just more comfortable?
more comfortable, and it's just the rest for, there's always small rest for aspiration, rest for like people throwing up. Or you don't, yeah, do you see where I'm coming from? It's very, very, for us in the critical care medicine, we look at, we look at,
no,
yeah, you see what I mean?
I'm
So-
surprised that in the da.
Yeah, it's so I tell my patient.
So in other words,
Right.
throw up in your mouth.
Oh my God, this is gonna go back to the lungs. Yeah,
Okay.
and that's a disaster. That's what I worry about. Like I worry about like the small possibility of acid reflux or throwing up or like being sick, and you have the habit of doing it. So my patient, I recommend chin strap. It's more comfortable. So a lot of people believe that breathing through the nose is better for you than the mouth for multiple reasons. Some people are mouth breathers. Sometimes it's a problem if you have sinus congestion.
Yeah.
So I don't like to use a judgment on a daily basis. So if you're having a lot of allergies, I tell my patient, sinus washes. It's like brushing your teeth. You do it every day with like neti pot or the Nazi pure.
So lavage.
Yes.
Can it be fresh water? Should it be saline? What?
I have to say to get like clean water, sterile water,
Or just
but
water?
to be honest with you, I do it like tap water. But
Yeah.
I have to recommend it.
Shower.
Yes, exactly. So going back to the habit, just make it a doable habit. If you don't do it, it's going to be hard. And yes. So the sterile water is the safest just because you don't want to have any contamination in the water. But you can do the sinus washes daily. Especially in the Midwest, it's allergies everywhere. So, and then if you don't have that congestion, taping the mouth, I don't have anything against it. It's not, how with the trend, like people believe, this is going to change everything.
Yeah.
Look, small changes, we don't have magical solutions, except my magic touch when I see medication. But we don't have a magical solution, but it's a small changes in our behavior.
Yeah, I honestly, I did it because, nasal pillows and my mouth would dry out.
Yeah, and I think a chin strap would be a great option for you to try it. Really try it. I think it's more comfortable than the tape.
Because I probably do have a little reflux.
Yes. And then a little bit head of the bed elevation can help. If you're going to do my rules of 4, 3, 2, 1, with no food 2 hours before or 3 hours before bed and 2 hours, it's going to help with the acid reflux.
Are you giving us a quiz later? Because I think I'm
going to test.
I think I'm getting 100%.
Well, Dr. Jarbou, thank you so much for this
Absolutely.
insightful conversation. I can't wait for a second follow-up episode here.
We're going to do it. If you're in for the VO2 max and sleep study, we'll be glad to do it for you and show you how we do it and give you the data and show you how you can change your behavior.
That's one more reason.
And maybe
Mid-Missouri.
yes, and maybe his girlfriend going to like it. And maybe neighbor's going to stop complaining about his snoring. I'm joking.
Actually, by this time, she's going to be fiance.
Oh, congratulations. Well, that's
By the time this episode comes out,
that's a huge, very good.
Yeah.
Congratulations.
Thank you so much. This is great.
Thank you, Dr. Stanford. Thanks to thank you.
Thanks for joining us on the Precision Medicine Made Simple podcast. If this episode inspired you to learn more about your health, please leave us a review and share the podcast with a friend. Your feedback helps spread the word about the power of precision medicine. Remember, taking action today can lead to a healthier tomorrow. See you next time.